Welcome to VNEW Health, powered by ARMS Medical, where we explore transformative solutions in women's health with insights from experts and real patient stories. Today's episode is brought to you by Zyve 7, digestive and gut health supplement dedicated to advancing wellness from within. I'm Robert Greer, and we're thrilled to have Dr. John Labban, a leading urogynecologist from Indiana University, right here in beautiful Bloomington, along with one of his patients, Miss Victoria, joining us in the studio. Together, they're going to share their journey with pelvic organ prolapse, or POP. In today's discussion, you're going to learn the importance of seeking the help of pelvic organ prolapse early, how a personalized patient-centered approach can transform outcomes, and hear why recent advancements in POP treatment are bringing new hope to patients across the country. If these topics resonate with you, don't forget to hit the like button down below, subscribe to VNEW Health, and of course, share this episode with friends or colleagues who you think might benefit. Let's spread the word of these essential women's health topics. Welcome, Dr. Labban. Dr. Labban, thank you for joining us this afternoon and being a part of Indiana University, where you serve the Bloomington community. How has working in this particular part of Indiana, how has it shaped your approach to urogynecology and, of course, the way you address these complex conditions like POP?
Well, first, thank you, Robert, for having me on your podcast. I've been in Indiana for 23 years now, in Bloomington, Indiana. I've delivered a lot of babies here, around 6,000 babies. I've been doing both OB and GYN for all these years. I'm an independent, so I was pretty much on call all the time. A few months ago, I had planned to stop OB and just focus on doing GYN. So starting July 1st, I've been focusing on gynecology. I've been doing obviously urogynecology for many years, and I've been through all the changes and the ups and downs and of the mesh initially, and then it got too crowded. Someday we'll have a good mesh, someday we'll have a bad product, up to the point that this whole ordeal invited lawyers to say, enough mesh, let's move on to something else. And I was lucky to know that there was a company in Florida that makes a cadaver graft, and I was very interested in trying that product. I've been doing it, Robert, tell me, maybe like 4 or 5 years, and I'm very happy with what I see.
Well, thanks for sharing that, and of course your background. Going from so many deliveries, and of course you've always been treating these ladies for gynecology, right? Which is what you normally deal with after you have some of these babies, multiple babies, and of course different factors like genetics and diabetes, weight, all of those things. So for those ladies, because this is primarily talking directly to them, how would you explain pelvic organ prolapse and how it affects a patient's lives?
We hear a lot about what we call pelvic organ prolapse. The main 3 organs that kind of prolapse or pop up out of a woman's vagina would be, you have the bladder on the top that falls down, you have the uterus in the middle that can come out, and you have the rectum that can bulge up. So obviously you can imagine when a woman might be facing situations like that. Now this prolapse can be in different severity. You have mild, moderate, and severe. Mild when it's still inside the vagina, moderate when it's right outside, right at the entrance of the vagina, and then severe when it is sticking outside the vagina. That can be related with, for example, for a bladder with incontinence sometimes. Sometimes if the prolapse is very severe, actually the woman will not be able to empty her bladder and will end up with what we call retention, which is it goes beyond incontinence.
So let's pause there because, our ladies will probably have some questions. So you've got this mild, moderate, severe, right? What's that ratio, that mix that you normally treat these patients, like at least your patient population?
It varies. Some people come and they don't have a lot of symptoms. So on exam, depends if they have a mild prolapse. We talk about physical therapy. We talk about different lifestyle changes. But then sometimes you can have a mild bladder prolapse, but then it's severe or moderate to severe uterine prolapse or rectum. So you might treat one part of the prolapse different than another one. Of course, when you have a severe situation, that you can do, if it's a severe rectocele, then I will repair it the old-fashioned way and I add a graft to it. But then if you only have with it a mild cystocele, then I will just do the traditional way of repair.
So let's talk about like the patient and how they present to you. What's the normal chief complaint that gets them to book an appointment to somebody like yourself that specializes in pelvic medicine?
Sometimes they present uh, as a incontinence, and then they don't know sometimes that they have a prolapse. So upon exam, I will quantify their degree of prolapse. Sometimes they come to me, Dr. Labban, I have some pelvic pressure in my vagina or something sticking out. Unfortunately, this is a very private matter. So some women, they've been having this problem for many years, and they come, it's already a severe situation. Unfortunately, sometimes primary care physicians, they don't really address this situation, maybe because I don't know much about it. And then when they come to me, they're already in a severe form.
And so what are you talked about incontinent, right? And incontinence for our ladies out there is very simply that when you cough, laugh, or sneeze, you have many times leakage of urine into your pants, and of course, uh, because of that, pressure of your bladder is greater than what the pressure to keep it closed is, and so that's why you normally experience it, when you're coughing, laughing, or sneezing, as we would say. And so, uh, what are some other challenges that your patients maybe don't do because of this condition?
Yeah, of course. I mean, it can affect their sexual life, obviously. If the prolapse is significant, then intercourse will not be enjoyable, will be painful or uncomfortable. Now, there is also a situation that I did not really mention, but in severe cases, I've had few patients, not many, but where if the bladder is going down so severely, sticking to the outside, it might put retrograde pressure on the kidneys and affect the kidneys in a negative manner, and the patient will not know that her kidney is being affected.
And how would that be diagnosed?
Yeah, if I have a severe case like this, sometimes I do a renal ultrasound before surgery to see if there was any impact, any pressure impact coming from a full bladder that's not emptying. And I'm not sure if I mentioned that this before, these patients might end up with a recurrent UTI because the bladder there's so much prolapse that the urethra is kinked and it becomes some form of retention.
Yeah, and then not being able to completely empty then can lead to UTIs, right?
Now, something else I don't want to miss it too is let's talk about the rectum. So these patients will come with constipation. because what happened, like I mentioned before, with the rectum, and the rectum bulges up. So when somebody's trying to poop, the rectum so the stools will go up in that bulge and will not come out. Obviously, one way of doing it, a crude way of doing it, would be to put two fingers in your vagina and push your rectum down. And a graft, a regular repair with a graft will be a great plus. So it will make it stay straight. So she would be able to empty her bowels.
No, listen, that's fantastic information. It kind of sets the stage. And of course, if you're watching out there and you find this information resonating with you, do me a favor, subscribe, and you'll never miss an episode of VNEW Health. So if we look at your approach, because you kind of talked about it at the very beginning of going from mesh now to biologics, how would you say your technique has evolved over the years?
Sure. Before that, though, I want to mention something to be complete in what I'm saying is sometimes surgery is not possible for some patients. So let's see, somebody's still young and want to have more kids. Sometimes she's she has medical problems and she cannot go under anesthesia. Sometimes for financial reasons, she cannot afford surgery. So with these cases, and if the prolapse is kind of significant, I offer my patients a pessary trial. Sometimes it works, sometimes it does not, but at least that would be an option for them. But they know, I mean, if somebody in her 40s, 50s, and they're active. So, I mean, a pessary is not the best choice for them. I tell them it's like taking Tylenol for a headache for the rest of your life. So you need to fix the problem instead of just trying to numb it. Because, if you want to have intercourse, you're going to have to remove your pessary every time.
If they don't like the pessary, right? So they've said, okay, thanks, but I really don't want to have to do this the rest of my life. What's that? What does surgery look like, and how do you approach it in your mind?
Yeah. So, I mean, like to answer your question before, so it was an easy actually transition from since I've been doing that the mesh for many years. It was, I mean, I guess if you're a good surgeon, you can. It was an easy transition to go from a synthetic mesh to a
biologic and dermis.
Yeah, and then and I'm over the years I started to see the benefit comparing the mesh with a graft. A mesh is synthetic; it just stays there, and then some people might still feel it. There is a higher uh, um, problem with erosion when the vagina might not heal well, and the mesh is behind it. With the graft, this is very uncommon. The graft eventually becomes part of the tissue of the patient. It merges in. So and the feeling then after when they come to for a pelvic exam, you can feel like, I mean, with a mesh, you can feel like it's kind of rough tissue behind the vaginal mucosa. With a graft, it feels like I don't know if I can say it, but it feels like when you have like a mattress to sleep on and you have that cover, like an inch cover on the top of it. I mean, it's great.
You say anything you want, Dr. Labban, because you've been using it for multiple years, and we certainly, always appreciate your feedback, your insight, and certainly want to now welcome Victoria to the VNEW Health program. Victoria, thanks for joining us this afternoon and being so patient. So
Thanks for having me.
I see scrubs. So you're in the medical profession.
Yeah, I work in surgery. So I've been around a lot of surgeries and seen Dr. Labban do these before.
Okay. And so, as one medical professional to another, it's always, we all have our, internal connections of like, who does shoulders, who does back, who's the knee surgeon, and of course, who does urology, gynecology, like Dr. Labban. So it certainly is always kudos off to someone with his skill set, because the people inside the hospital usually know best.
Yeah, absolutely.
So if you don't mind, I know it's personal, but at the same time, it's so important for your journey, for your message, to get out and to be able to talk to these ladies, because uh, almost half of the women at the age of 50, so 50% at age 50, will have some sort of prolapse or stress urinary incontinence. And of course, prior to that, the numbers, keep creeping up depending on, other factors that we talked about at the beginning of the show. And so, what got you introduced, or was said, hey, I need to go see Dr. Labban? What was what was happening with your body, if you don't mind sharing?
Yeah, I'm happy to share. I'm pretty open about all of my experiences. So, first off, I have 9 kids. So,
Well,
um, it's
congratulations to that. That is
yeah.
absolutely
So I
fantastic.
think it would probably be more uncommon if I didn't have prolapse problems, first of all. After I think it was my fourth baby, I actually felt myself prolapse for the first time. Um, so I've known it was an issue for a long time. Obviously had some more kids after that. Then it got to be where I could just always feel the bulge, could feel dry tissue. Um, so I knew something was wrong. I mean, I've been in the healthcare field for a little while, worked around birth for a long time. So, I think when I went in to see Dr. Labban, I told him I had a prolapse before he checked it. I'm not certain that he believed me, but he did afterwards.
Did you believe her, Dr. Laban? Did you, did,
Well, I mean, she's young, but yeah, I knew that she had 9 kids. So I don't know. I had to see first.
Of course, of course. You're like, okay. But okay, so now it's been diagnosed, and now what were you thinking about what your options were going to be? Because you already were done having kids. What was going through your head of like, how do I want to approach the repair of what that trauma did to my body?
Yeah, so for me, I've had a few surgeries in the past, and I have always reacted to suture. So I've rejected suture. I've had, incisions come open because the suture, my body just did not like it at all. So that was really why I put off having a repair done for so long, because I was terrified of having mesh, and nobody wants to have their body reject things, in
Right.
your vagina. Not an ideal situation.
Exactly.
So, I actually, since I work in surgery and I do primarily orthopedics, so don't work in gynecology a whole lot, but I know people who do. And one of our staff members here recommended, she said Dr. Labban does a repair that doesn't use mesh. So that's why I picked Dr. Labban, because I didn't want to have mesh. I was just afraid of the complications.
Sure. And so, what did you have before, like hernia repair, or just the sutures itself were a problem?
I had a hernia repair, and that I had problems with that. I actually had an abdominoplasty and had problems with that too. So it was a long history, and it
And and
was
so, and,
not
and
fun.
so and so, Dr. Laban, when someone comes in and says, "Hey, I don't want to have mesh, but I also have issues with polypropylene," then I would assume you then go, okay, so what's my suture selection? What's my technique? Do I need to change anything? How do you address some of uh, those scenarios where people have allergies?
Well, we usually, I mean, not just in case of Victoria, but sometimes when people tell us that they are allergic to a certain suture, then we try to use a different suture. And there are so many sutures on the market that we can use. Um, Back then, I'm not sure. Maybe Victoria, if you can tell me, what I still doing, I don't think I was still doing meshes anymore. I had shifted completely to the
Yeah.
graph and was pleased with it.
Yeah, you were completely doing grafts then at that time. But I'm kind of a special case because I've got a lot of medication allergies, and Dr. Labban really works carefully with anesthesia on that to make sure that we avoided anything that would be a problem.
Sure. No, absolutely. And it, I guess I always look at it and go, it's testament to the DNA removal process of the dermaPure VNEW that you didn't have a reaction. Is that so? I assume, for we're not sharing and talking with Dr. Labban, let's talk about the outcome, and of course maybe leading up to it, how you prepare yourself to go into surgery.
The outcome, if you want to cover that first, I didn't have any sort of reaction to it at all. The recovery from the graft side was not painless, but it was pretty easy. I think I got they gave me a pain pump, and I think I only used it one time, and that was only because they were about to take it away from me. And the nurse was like, "Are you sure you're fine?" And I was like, "Okay." So
Right.
from that side, it was fine. I did have a little bit of residual pain in my tailbone, just from, I assume, from all the things that were attached to the coccyx that it wasn't used to having attached to it, or to the ligaments rather.
Right.
But other than that, it was a pretty simple recovery. Not the worst recovery I've ever had, for sure. Preparing myself to go into it, I think I was careful to have things laid out beside my bed, things that I knew I was going to need. My family was prepared to know that they were going to have to take care of me for a few days and bring the things that I need, because I wouldn't be able to lift or carry anything. I still have young kids, so I think the youngest was 5 then. And so he knew, I can't pick him up. He can climb up on my bed and I'll give him hugs and love on him, but I couldn't pick him up. So, but I think just being prepared, and forcing myself to have some downtime. I don't like to sit and not go, so that was a little bit difficult. And I'm still in school full time, so I was able to get a lot of schoolwork done from bed.
There you go. It was forced, right? It was forced upon you.
Yeah.
No, that's fantastic, and certainly thanks for sharing that with us. From a, I'll say a recovery standpoint, when did you feel like, okay, not now, I can feel that it's improved because it's in a position where it's supposed to be, right? And then second is, okay, now I feel like, completely recovered. 6 weeks, 8 weeks, 12 weeks, 3 months, what was your kind of that time period for people that are thinking about the surgery? How should they approach it?
So in a lot of ways, I think it was kind of like recovering from childbirth, and I actually forgot that I got a lot of supplies that I would have on hand for after childbirth. A peri bottle to spray things off with, and witch hazel pads and all of that, just to help with the swelling. So, in that manner, but I think really, other than some swelling, I could tell it was better almost immediately. I mean, obviously, I could tell that it were swollen tissues. It wasn't comfortable, but as far as the prolapse, I could tell a difference. I noticed a difference with my bladder pretty much immediately, as soon as I didn't have a catheter anymore. Just, when I would cough, I didn't have to worry about leaking. That was pretty quick. As far as feeling back to normal, I think that probably took probably 3 to 4 weeks. But again, I think most of that was just the tailbone pain. It wasn't the actual tissue pain. But it really, I think as far as the tissues go, it was probably about 3 weeks when I felt okay for just about anything.
I mean, that's impressive because, a sprained ankle take 6 to 10 weeks,
Yeah.
So that's positive to both to yourself having a speedy recovery, and of course, Dr. Labban, your surgical technique and your surgical approach. So how long has it been since you've been post operation with
I
biologic?
I think we're almost exactly at a year right now.
Okay. And so everything's good. Life is good.
Yeah,
Yeah, everything's
yeah,
back where it's supposed to be.
yes, it is. No more splinting like Dr. LeBlanc was talking about earlier. Not if that may be TMI, but no more of that.
So a lot of ladies watch the program. You're in the profession. You sought out someone like Dr. Labban. What advice would you give others that are experiencing the symptoms that you had, and then of course are hesitant about seeking treatment?
I think the main thing is don't put it off. As long as you know you're done having kids, I don't see any reason to not go ahead and get it done. Because the younger you are, the better you're going to heal, the easier recovery is going to be. Um, I think a lot of people, their main concern is mesh. And so find a doctor who will do an alternative to mesh. Um, so that takes away one of um, the big factors that could be a concern.
And so the I can kind of sense Dr. Labban, you, Victoria, you've got this patient physician relationship. Um, Anything you can share about the importance of that relationship, because you're getting wheeled back to the OR, right? So you want there's a lot of trust in there, and certainly I know that you do. So how would you want other ladies to think about some of the questions, or how they should think about that relationship with someone like Dr. Labban?
I think for me, the main thing that I look for in a provider, excuse me, is someone who is not afraid of me asking questions, who's willing to sit down and explain to me. And if I say, well, why do you want to do that instead of this? So like Dr. Laban and I had a discussion about whether I was going to keep my uterus or not. And he was very patient and kind with me and said, are you done with it? Are you going to use it anymore? So we did do a hysterectomy at the same time. I kept my ovaries. And so I think finding somebody who is, I guess, doesn't have a God complex and is willing to sit down and, tell you their rationale. And so you can have a back and forth and say, this is what's important to me. And so they can know, and make a plan based on your specific needs and have patient-centered care.
So, Dr. Labban, same question, right? Sounds like you were pushing all the right buttons. What are some of the things that you try to get your patients to open up about, or how do you approach that? Because you talked about it at the beginning of the show, it's very private, right? It's a very
Yeah,
private
you're
topic.
right. I mean, I guess it takes a certain personality to feel like you're there for the woman in need. But to begin with, it's written on my website too. The way I deal with my patients, one, of course, mutual respect. And then second of all, it's a mutual decision making. I never try to push something on a patient. It's funny, in any surgery, I give patients options all the time. And then I tell them what I think it would be best. And I tell them, that's your homework. Go home, discuss it with your partner or your husband, and then let me know. So this is how it should be. I mean, people are smart. They read, they talk to other people. It's not, medicine is not like it used to be years ago, patronizing. You sit down and talk to your patient, and yeah, like you said, I mean, our specialty is really special. It's we're talking about private stuff.
Yeah, I think that's important. I think if you look at your Facebook page, how do people follow you on Facebook? Because I know you have thousands of women that do so. What's that? That link?
Yeah, it's John Labban. MDPC Women's Health.
Perfect. And I know that we will get that on the screen, so you'll be able to see it and certainly click on it. And you'll be able to, we could put it in the chat down below for this particular show. And so I want to thank both Victoria for coming on and sharing her experience and giving women hope and a pathway to feeling better. And of course, for Dr. Labban for being innovative in how he approaches women's health and offers a solution that is avoiding different products that some of these women want to avoid. So it's very special that you can offer this to the ladies of Bloomington, Indiana. And of course, we'll put your website up on the screen. Dr. Labban, if you want to just read it out to everybody, how do they find you? What's your website?
Yeah, my website is drlabban women.com.
Perfect. And we'll put that on the screen so you can certainly click on that link. And of course, we always want to thank Zyve7, our sponsor, for their support in advancing wellness. Of course, until next time, take care and stay informed. We hope this episode has brought value to you. And if it has, of course, please subscribe to VNEW Health. Leave a review and share it with others. Final remarks to our sponsor, Zyve7, and their support in advancing wellness. Until next time, take care, and of course, stay informed.